good afternoon, or good whatever it is in the time zone that you're in. I'm on East Coast time, so it is uh, almost 1 o'clock in the afternoon. I'm Dr. Margaret Fitzgerald. I'll be leading the program today. Mr. Brian Austin is on with us for support, so we're in very good hands. And we're going to wait literally one more minute to get going so that we are at the top of the hour, and look forward to this session with you. And hope for those of you who have been in the midst of this rather nasty winter that good part of the country has been having, is that you are safe and warm. I was talking to somebody the other day from Utah who said, can you people in Boston send us our weather? Apparently you captured our weather and haven't given it back to us. They were saying it was 50 degrees in Utah and the mountains are bare of snow. And we're in Boston in what feels like a perpetual deep freeze, which we seldom get. All right, 'tis the top of the hour. Let's get going. And welcome to the session on Ask and Apply Live Exam Strategy. I'm Dr. Margaret Fitzgerald. I am the founder of Fitzgerald Health Education Associates. I've been privileged to teach NP review to more. I and my team have taught NP review to more than 180,000 nurse practitioners over the years with spectacular outcomes. And with that, let's get going. And what couple of other things about me, my clinical practice has been in family-centered primary care / urgent care. My practice has been kind of like about a 60-40 mix, 60% primary care, 40% urgent care. Some days are flipped the other way around. And I love, 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 love that variety. I'm also on faculty at Case Western Reserve University in Cleveland, Ohio, where that's where I did my doctoral studies, and I sit on the Pharmacy and Therapeutics Committee for a major HMO based out of Boston. And I do about a dozen other things. And the reason why, if you've been on of these sessions, you'll say, why does she keep saying that? Part of it is, first of all, a lot of people just drop in for one or two of these sessions. Some people come to all of them. Everyone is unique. But one of the main reasons why I like to mention what it is I've been able to do as a nurse practitioner, because right now you might be at that proverbial whose big idea was this? Like, why did I even bother becoming a nurse practitioner? This has been so much work and it's such a responsible position, et cetera. But it is a position that is going to open doors that you didn't even realize existed. So this will all be good in the long run. Okay, so a few reminders here. Technical or customer service questions, please send those to Brian in the chat. And questions to me about the NP boards, please put those in the Q&A. And if you're wondering where the Q&A box is, look at your control bar for Zoom. Mine sits at the top of my screen. I appreciate some people will have it at the bottom of the screen. And if you go over to the full control bar, way over to the right, there is a circle with 3 dots in it. And what that circle with the 3 dots says is more, M-O-R-E. Click on that and what the Q&A box will come up. And one thing about the Q&A box, I'm the only one that can see what's in there. So you can be very candid about your questions. And while I'll have maybe 25 minutes of prepared remarks, and then I'm going to turn it over to you folks for your questions. What I want you to do while I'm talking is tell me what is perplexing you the most. What do you feel like is getting in your way the most of getting ready for boards? Because what I know is most of you are towards the end of your NP program, or you've recently graduated. It's one or the other. And so you're in kind of like that home stretch of getting ready for boards. And even if you decided to hop on these early and you're not in the home stretch, welcome. Thrilled that you are here. But what I want you to do is be as specific as possible on the content. So not like, I don't understand type 2 diabetes drugs, but more, I'm not clear on when you prioritize this med over that med. Okay. So I want your question as focused as possible and as clear as possible. I also kindly ask you, if you're confused about a sample question, a practice question that did not come from Fitzgerald Health Education Associates, and you don't know why another author said this answer is correct when you think it's not, I will not answer those questions. You have to go back to the original author and ask them. If it's a question from my book that you're perplexed about or our review course, fair game, fair game. I will answer those, but I will not entertain questions that have been authored by somebody other than a member of the FHEA faculty. And a lot of times it's me, okay? Because I don't know what their rationale was, and you have to go back to the source there. And I realize one of the reasons why a lot of times people ask me those questions is they try to get the original author outside of FHEA to answer the question, and they won't respond, okay? So what are the purposes of these sessions? Our main goal is to support your success and to answer your concerns, your questions, concerns as you are getting ready for boards. Now, I'm going to tell you something. One thing these sessions are not one bit about, not one iota, is improving your test taking. To which you're going like, okay, well, I'm going to give myself back an hour. I wanted to be on this session learning about test taking. No. Here's the deal. Folks, you have at bare minimum a master's degree. Many of you, this is your second master's or a postgraduate certificate or a doctoral degree or a postdoctoral certificate. You are an outstanding test taker. And if you say, yeah, but you don't know me. You know what? I know enough about you looking at your academic success. I know enough about you to say that. So do not fall for this, that you're a rotten test taker and you're going to die of test taking anxiety. Okay. You know what? You will be anxious on the day of the boards. No two ways around it. But you know what you need to work on to be successful on boards is clinical decision-making skills. So what we want to do with our review course plus these sessions is enhance your knowledge base and sharpen your clinical decision-making skills. Because what are the boards all about? They are testing to see if you will be that safe clinical decision maker. That's what it's all about. And remember, the boards are a highly vetted exam, meaning they truly test what they're supposed to be testing for, which is, to be honest with you, think it through, it's public safety, because your boards are used as part of you getting a license to practice, right? So please keep that in mind. Here is another thing. Always remember, when you are studying for these exams, the boards are not based on what you studied in school. This is not a gigantic final exam. No. They are based on what practicing entry-level NPs in primary care do. Did you catch that? Entry-level NP in primary care do. And I say primary care because everybody on this session is either family or AGNP primary care. Okay, we don't have any acute care people or anything like that on there. So please keep that in mind. And I know only about 40% of you will practice in primary care, But on the other hand, while you're getting ready for boards, regardless of what you plan to do as an NP, think like a primary care provider. So how should you study? Purpose, intent, and goals. It is best achieved with a well-developed plan that enhances the knowledge base and sharpen your clinical decision-making skills. Use practice questions to wrap up, not start your board study. All right. I am privileged to teach a remediation class for people who have failed boards. And invariably, people who have failed boards have said to me, how the heck could I have failed boards? I did 5,000 practice questions. I did 10,000 practice questions. I said, what did you do to build your knowledge base? What did you do to hone your clinical decision-making skills? And they'll say, well, nothing in particular. And I said, see, herein lies the issue. You cannot teach yourself this clinical decision-making by simply hammering yourself with practice questions. You can't. It does not work, right? So the last session, we really focused in on the last session, which was 2 weeks ago. February is flying by. I know it's a short month, but it is flying by. So 2 weeks ago, I went in depth on the domains of assessment and diagnosis. So what I'm going to do now is go into depth with the last two domains of the 4 domains of the NP boards, okay? Plan. So plan is pretty self-explanatory. It's developing a plan of care. You want to think of broad strokes of intervention. This is where the pharmacology really plays in to what is on the boards, okay? Most med questions are safety questions. Please keep that in mind. With questions on who should be given a med, this will be by evidence-based standards, and who should not, one more time, with a focus on safety. So broad strokes of intervention, okay? Few things you want to keep in mind with this. Throughout a person's lifespan, pharmacodynamics, PD, what the drug does to body and or disease, it includes the drug's mechanism of action, remains constant. Well, pharmacokinetics, PK, what the body does to the drug, including absorption, distribution, metabolism, and elimination, varies. So pharmacodynamics knows no age. The way a med worked on a 2-minute-old baby is the way it works on a 102-year-old adult. Now, pharmacokinetically, what a healthy 25-year-old will do with a med versus as far as absorbing, distributing, biotransforming, or metabolizing the drug and getting rid of it, what a healthy 25-year-old will do to any drug compared to like, excuse me, like the 85-year-old with stage 4 CKD, totally different ballgame. So pharmacokinetics varies tremendously over the lifespan. Pharmacodynamics remains consistent. And you know what? If you say, well, that's a new concept, it was like, no, you all learned that in pharmacology. One of the issues is you probably took pharmacology before you realized how much you needed pharmacology. And what I mean by that is that the way NP programs are lined up, usually the 3 Ps, pathophysiology, pharmacology, and physical assessment, are all front-loaded before you go into your didactics or your role prep courses. And then, you study the 3 Ps and then you go like, I don't necessarily remember what it is I need to know from those courses because I took them a year and a half ago. And if you think, oh yeah, that's NP education. I have taught medical students, I've taught family practice residents. They have the exact same problem. So it's not just nursing. Major drug adverse effects tend to be found consistently across a drug class and are often consistent with the drug's mechanism of action, okay? So drug adverse effects across the drug class. The ACE inhibitors all have the pril suffix on them. If I had to say which ACE inhibitor is going to land on the boards, it probably will be lisinopril. It's on the $4 drug list. It's a nice once-a-day drug. It's cheap, cheap, cheap. And April is April is April. They all work the exact same way. And upwards to 8% of the general population will develop a cough on an ACE inhibitor. 8%. Is it tied to airway disease like asthma, COPD? Absolutely not, because it's not a bronchospastic cough, not bronchospastic. Okay. Now, another adverse effect you might hear about with the ACE inhibitors is angioedema, swelling of the soft tissue of the face, the neck, and including the tongue that can result in upper airway obstruction. Monica Tambasco, who teaches for FHEA, is a former student of mine from many, many years ago, who's both an NP and a CRNA. And she has seen angioedema when she's working in the ER. She does that. She works in an ER. She practices as a CRNA. She's had to intubate a couple of patients over her years of practice with the angioedema from an ACE inhibitor, because the tongue is so swollen, the person can't maintain their airway. Okay. The angioedema is rare, but potentially life-threatening. Who's most likely to get that angioedema? A person who also has angioedema when they take an NSAID, right? And it looks like it is slightly more common in people of African and Latino ancestry. All right. So I just went on and on about the angioedema. That's in real practice, you better know that. But which is going to pop up on boards? The cough. Okay. Your patient started on a new high blood pressure medicine 2 weeks ago, now comes in saying, I've got this dry cough that just won't go away. They don't have a URI, blah, 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 blah. What was likely the blood pressure medicine they were started on? And the correct answer would be an ACE inhibitor. And it's a dry, hacking kind of bothersome cough. I've actually had one patient who developed their ACE inhibitor cough 5 years after starting her ACE inhibitor, 5 years. So a lot of times it comes on pretty soon. Sometimes it's years later. Okay. The fluoroquinolones, antibiotics that all have the floxacin suffix. To give you a couple of examples, levofloxacin versus moxifloxacin. What's one of the adverse effects you hear with these? Tendon rupture. Most common, Achilles. One study said it would be 90% of the tendon ruptures were Achilles. The other is, and don't ask me the name of it, but the tendon at the base of your thumb, that has a special name. I just don't remember it. And particularly when used with systemic corticosteroids, like somebody who is given a fluoroquinolone, plus they need a burst of prednisone to manage an asthma or COPD flare. Okay. So you want a fluoroquinolone, you want the coverage of a fluoroquinolone, but you don't want to risk the tendon rupture, particularly in an older adult who's also taking a systemic corticosteroid, like that 75-year-old with a COPD who you're really kind of concerned about the tendon rupture risk. What you can do is do a cephalosporin or do doxycycline. Okay. You can just avoid it. Okay. Beta-2 adrenergic agonists, more commonly just called the beta-2 agonists, all have a terol suffix on them. So they all work the same way. Albuterol works the exact same way as salmeterol or formoterol, but albuterol is what's known as a SABA, S-A-B-A, short-acting beta-2 agonist, and formoterol, salmeterol are known as LABAs, long-acting beta-2 agonists. So they all work the exact same way. The difference between an albuterol and a formoterol, an albuterol and a salmeterol, is duration of action, okay? Where albuterol hangs around clinically active for about 4 to 6 hours, and one of the LABAs will hang around for 8 to 12 hours, okay? So here is a good thing to remember back to Pharm 101. Beta 2 adrenergic agonist. What does that mean? Beta 2, it hits the beta 2 receptor sites. Now, and if you're going like, oh yeah, I remember there's something to remember about beta 1, beta 2. Beta 2 receptor sites are found in abundance in your 2 arms, your 2 legs, and the airways going to your 2 lungs. Agonist is a drug that goes to the receptor site and activates its natural action. So when you activate the beta 2 receptor sites in the airways, you get bronchodilation. And even though we're using these drugs inhaled, when people get if they get, quote, too much of something, and it's usually albuterol on board. Like if they've got access to a nebulizer and they've been nebulizing the dickens out of themselves because they've been sitting at home for 5 days with an asthma flare, they can often come in and they're like this, they're tremulous because that super high dose of albuterol has hit the beta 2 receptor sites in their 2 arms and their 2 legs. Just they don't notice the tremor in their legs. Sometimes their feet will tremor too. Have you ever had anyone tell you who just got a nebulized albuterol treatment, I feel like my heart's pounding? Yeah. And then you check their heart rate's like 88, it's not 120. It's because the beta 2 receptor sites in the heart have been stimulated, which makes the heart contract more forcefully, okay? More tremor with SABAs than with LABAs, as a general rule, because the SABAs just kick in a lot more quickly, okay? So tremor, common adverse effect, common is going to occur on the boards. Now, the SGLT2Is, the SGLT2Is, all of these, this is type 2 diabetes drug, obviously, have the gliflozin suffix on them. Canagliflozin, empagliflozin. How do these work? These work by causing the kidneys to offload sugar when the blood sugar rises, but only when the blood sugar rises. So and the average person on one of these drugs will pee out about 200 sugar calories per day. That's the average. That's the average. So there are a couple of things to keep in mind with these meds. One, if you do a urine dip for sugar to a person on an SGLT2I, you go, yeah, yep, there's sugar in the urine, okay? In other words, it's an anticipated effect. That's there is sugar in the urine. However, because now the people are peeing out sugar, people with that tendency towards genital candidiasis are more likely to get genital candidiasis. People with recurrent UTIs, more likely to get another UTI because Candida loves sugar. Bacteria love sugar. So genital candidiasis, and I should have thrown this up there too, UTIs are common-ish adverse effects with the SGLT2Is. And by the way, since I'm talking about the SGLT2Is, I can't seem to say that today. One other thing to remember is that the SGLT2Is, you'll often hear that weight loss can go along with their use. Well, let's face it, if a person cuts back their caloric intake by 200 calories a day, they could, over time, lose weight. But now let's just kind of do the math in our head. 200 calories a day times 7 days a week equals 1,400 calories, right? A pound of fat has about 3,500 calories in it. So over the course of roughly 3 weeks, that person would lose 1 pound of body fat. Often what happens is somebody goes on an SGLT2I on a Monday. And by Friday, they'll say, I'm down a half a pound. Okay. Boy, I was told I'd lose some weight, but wow, this is pretty fast. And when you think about it, okay, if they're down a half a pound and that's a little too fast for simply the caloric deficit, but the SGLT2Is, where sugar goes, water goes, they have a mild diuretic effect. And that is why the SGLT2Is are being used in people with heart failure who don't have diabetes. It's part of standard of care, right? So something to keep in mind there, okay? Plan. These are other things you need to consider with prescribing. You will not be asked to memorize or calculate drug doses. Will not. That's considered lookup information. Now, what I've had people say to me is, yeah, but I had questions that had drug doses in it. Yeah, and that's more, should you bump the med up or reduce it? It is not asking you what's the safe starting dose of an ACE inhibitor in a person with a GFR of 25, stage 4 CKD. No, because that's a calculated out, all right? But you might be asked something like, if you remember, if you've been through the Fitzgerald review course, there is a question on a woman who's on, I don't know, she might be on like 75 micrograms of levothyroxine, but her TSH is too high. And the correct answer is you need to bump up her dose and recheck her TSH in 2 months. Okay. So that's not a drug dose question. That's a recognizing that somebody is subtherapeutic. That's what it is. So it's not a memorizing a drug dose. The other thing is information on the exam will be at least 12 months old. And newly launched therapies and guidelines are unlikely to be on the test. But please remember, the test is, shall we say, refreshed every year, particularly AANP. And the other thing is clinical guidelines that are oriented towards primary care diagnoses, like hypertension, dyslipidemia, type 2 diabetes. I've been doing this for a long time, folks. Never, ever does a group come out, ADA, ACC, et cetera, come out and go, oh, you know how we were treating dyslipidemia all those years with statins? Well, we're throwing that all out. We're going to give you a brand new set of guidelines with a whole bunch of new drugs. No. Guidelines tend to be tweaked a little bit based on new research. Sometimes it is newer treatment options, but a lot of times it's more, oh, okay, we've been able, like I'm going to go back to the example of the SGLT2Is. When the first year they came on market, which was 10, 12 years ago, the first year they came on market, there were none of these like, oh, this is a preferential drug in CKD or a few other conditions. No. We didn't have those data yet. Okay. We've got them now. And so they're mentioned in the guidelines. So in other words, with newer guidelines, a lot of times it's an enhancing of what we already knew. Okay. And so if you happen to hear like a month before your boards that a brand new drug for fill in the blank came to market, it's not going to be anywhere near your boards. Now, your last domain, evaluate. This includes assessing the patient's attainment of treatment goals and the ongoing need to adjust the plan of care. This is how you need to think, folks. Most of you are coming from the acute care setting where even with the patients that you've been privileged to see a lot in your RN level practice, like the people who come to the ER on a regular basis. I was an ICU nurse before I became a nurse practitioner. We had some people that we saw all the time in the ICU. You know, the proverbial frequent flyers. They did come in, they even existed back then. In other words, people that we got to know really well, we got to know their families very well, etc. But what you have to realize is primary care is based on a longitudinal relationship with a patient aimed at working with the patient to achieve and maintain the best health possible. And the questions will reflect that and reflect that really, really, really well. Okay. So let's take a quick look at a evaluation question here. So this is evaluate. Remember, the patient has been diagnosed, the patient has been treated, right? And now you're looking at response to care evaluation. And by the way, the boards are about 25 to 30% assessment questions, roughly 20% diagnosis questions, roughly 25 to 30% plan questions, and then roughly 20% evaluation questions. Depending on which board you're going to sit for, go back to their website and they'll lay it out better for you. A 55-year-old adult with primary hypertension diagnosed 4 months ago is currently taking standard dose ARB. All right, there's an expectation. You're going to see the word ARB or the letters ARB and know that that is an angiotensin receptor blocker, a certain drug like telmisartan. He's feeling well and denying headache, dizziness, chest pain, or visual changes. He states, I'm trying to eat a healthier diet and I'm walking about a half an hour 4 times a week. His BP at the time of diagnosis was 148 over 88, and today is 138 over 82. So do you notice that his BP went down on this med by about 10 millimeters of mercury systolic and about 6 diastolic? That is standard reduction for that drug class. It's about how much you're going to squeeze out of it. Which of the following is the most appropriate next step? A, continue with the current therapy with a 6-month follow-up. B, switch from an ARB to a calcium channel blocker with a 2-month follow-up. C, add a low-dose thiazide diuretic with a 1-month follow-up. D, check a BUN, creatinine, CBC, and WBC with a differential and arrange a 4-month follow-up. Okay. So I would be willing to bet, I'm going to walk you through these. A, continue current therapy with 6-month follow-up. That says, no, his BP is okay. No, his BP is too high. His BP is too high, should be less than 130 over less than 80. B, switch from an ARB to a CCB with a 2-month follow-up. No, he's not at goal. Switching out a well-tolerated medication is not appropriate. Plus, the guidelines say recheck in 1 month after you adjust a drug dose and or add a new drug. Okay. C, add a low-dose thiazide diuretic with a 1-month follow-up. Yes and yes. That adding a second drug with 1-month follow-up consistent with the AHA-ACC recommendations. D, check a BUN, creatinine, CBC with WBC diff and see a 3-month follow-up. Here is something you always, always, always need to ask. Why? Never do a test that does not address your diagnosis or your treatment plan. It doesn't, there's no reason for you to be rechecking renal function. And with a question like this, CBC with WBC diff, when this is clearly a med question, the only time we check CBC with WBC diff in a person who feels well, remember it says he feels good, Okay. Is its blood pressure still a little bit too high? The only time we check a CBC and a WBC diff when it is associated with using a med is if we think this is a drug that could have caused bone marrow suppression. You're not going to get a question like that on boards. And I'll give you kind of a quick and dirty example of a few drugs that we occasionally are obligated to check CBC with WBC diff on periodically. Some older anti-epileptic drugs like carbamazepine, Tegretol, valproic acid, Depakote. And those are drugs that are just not going to crop up on your boards because they're not used the way they once were. Okay. So that's the way you would think your way through this. And you know what? I've been trying to add this to this session a few times. I promise I'll try to sneak it in the next time because I think this is important for you to know. But that took me a little bit longer to get through than I thought. So we'll save that for next time. And please, you know what I'd like from you guys? Give me feedback. Is it helpful going through stuff like this? Okay. Were you able to discover weakness in studying for those who failed the exam as mentioned in the last webinar? Yep. Universally, no attempt to increase knowledge. Okay. To know the how, what, and why of practice. And if you're saying, well, what's the how, what, and why of practice? It's in chapter 1 of the Fitzgerald review course. And what they've said is, but I did 500, 5,000, 10,000 practice questions. And I'll say, okay, well, first of all, how are you doing on the practice questions? I was scoring in the high 60s, and I just kept getting feedback that that's a good score. I'll pass boards. No, it isn't. The other thing is, if you're consistently scoring like that, it's not telling you you're a rotten test taker or you have crippling test anxiety. What it's telling you is the following. It is telling you that your clinical decision-making skills are not where they need to be. And that what you need to know is, remember, pathophysiology leads to physical assessment. Physical assessment leads to diagnosis. And remember, physical assessment, I'm not just talking about, oh, I listen to the heart and lungs. Physical assessment includes a whole ball of wax of history of present illness, plus the physical exam, okay? Because that's really, really key to putting those together. So I know it's tempting to say, I just got home from a 7P to a 7A. And of course, my 7 a.m. shift that was supposed to end then didn't end till 7:45. And then I hit traffic coming home from work, and I didn't get home until 8:30, 9 a.m. And I'm really hungry, but I'm also exhausted, but I'm going to do 50 practice questions. No, don't bother. Just don't bother. Get some sleep. And then if you go to the spiral bound workbook that came with your review class from Fitzgerald Health, you all got one. There is an article on developing your study plan. And the way I recommend you develop your study plan is 2-hour blocks of study. And if you say, oh, 2 hours is too long for me, okay, make it an hour. But what I want you to do, which each study block is have a topic and outcomes. A topic and outcomes, right? And what you expect to get out of it. And some of this will be learning more about it, like if it's thyroid, and I often mention thyroid because it's so easy to pick on, is saying, gee, I'm still baffled about the clinical presentation of hypo versus hyper. Okay, that tells me, when you tell me clinical manifestation, you need to go back and understand what thyroid hormone does. It's all there in your review course. And it's also there in my book, in the endocrine chapter. Okay. So, I'm going to do a deep dive into understanding the pathophysiology of the disease. Then that makes all the physical exam findings fall into place. Then that makes interpreting the labs easier. And then what I'm going to do is have the basics of prescribing. Okay. Most of the questions on boards will be hypothyroidism because hyper we just don't see it that often. It's, way, way, way less common than hypothyroidism. And so then you'll be able to develop your treatment plan. And you'll also be able to say, okay, this is what I needed to get out of that study block, and be able to self-eval and say, okay, I really did get that. Okay, there's so much information to remember. I'm scheduled to take my ANCC family exam on April 4th. How do I stay focused on what I really need to study successfully to pass the boards instead of focusing on everything? If it is in the Fitzgerald review course, there is a extraordinarily high likelihood it is going to be on the boards. And you're really fortunate in that you have access to the only review course on the market that is focused on clinical decision making. It truly is. So what you need to do is just what I was saying like a moment ago about about your study plan. So right now what you're doing is you're doing this. I need to learn everything. Well, you're going to feel over years in practice that you have learned almost everything. And remember, I say that from a primary care viewpoint because I am a primary care provider. I am extraordinarily well suited to be a primary care provider because I love, 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 love longitudinal relationships with people. I know there are some people like my dear friends in the emergency department that go, no, I don't want a long-term relationship with a patient. Okay, you do you. I love having longitudinal relationships with my patients. And what you want to do is focus in on what's in the review course, back it up with what's in my review book. And then the other part that you want to do is get rid of the yeah buts. Like, I was teaching a review course not long ago. I did the anemia section and somebody pipes in with, yeah, but you didn't cover leukemia and lymphoma and aplastic anemia. Yeah, you're right, I didn't. Are you heme onc as an RN? And the person said, yep, that's where I practice. Okay. That's because that's not going to come up on the boards. Okay. So that's what you have to do. You have to focus in. Board exam is on Thursday. Still nervous about ECG and some of the meds that are specific for arrhythmias. Forget it. Did I mention arrhythmias in the review course? I mean, other than recognizing atrial fib, which is easy enough to do. Did I mention it? No, I didn't. You know why? You might, underline the word might, get one ECG question, one out of 135 clinical/exam room questions that are going to be on your test that count towards your final score. One. Focus, get rid of that, push it to one side, push it to one side. You're focusing on something that will not show up on the boards. Or if it does, it's going to be literally a question. All right. So, and I wish you well. And you know what? You're always welcome to pop back in. We would love to hear. We would love to hear how you did. Now, here's something else I'm going to tell you. If you go to the AANP's website, and you should all be AANP members, because this is our professional organization. It is a professional obligation. And if you're still a student, sign up to squeeze the student membership out of them. Like let's say that you were going to graduate March 1st. You could go on the AANP's website and get student membership today. Okay. And you can take advantage of the student rate, even though you're only going to be a student for a couple of weeks. And then if you're already out, what you might find is that they have a discounted rate. I don't know, it's your first 1 or 2 years of practice. In other words, they appreciate that you're emerging from your poor student role. Okay. So you should do that. But back to what I was saying, if you look on the AANC's website, there is a role expectation list of things that you should be able to do when you're a nurse practitioner in primary care. So we're not talking acute care, primary care. And one of them is cardiac rhythm disturbance interpretation, and the other is 12-lead ECG interpretation. That's an expectation of the workplace, right? So don't be surprised if the workplace says, you don't know how to read a 12-lead ECG? Okay. Like I've mentored countless new grad NPs that I've taught how to read 12 leads because I know how to read a 12-lead ECG. And the ECGs on kids, on rare occasion, I'll do one on a child. I'll run that by pediatrics because kids have weird EKGs. They have like inverted T waves that we would panic over with adults, and it's normal on them, and it's due to their cardiac structure. But if you cannot read an ECG now and you're sitting for boards on Thursday, let it go. Let it go, and do not let it distract you from what will be on your boards and should be catching your attention. Regarding multiple answer questions, say if 2 out of the 3 questions correct answers are given, will any points be given for those 2? No, it's all or none. Now, here's something to keep in mind. AANP, every one of the questions will be the stem, the story of the question, and then 4 options. Okay. And they used to be like ABCD, or 1, 2, 3, 4. Now I think they're just radio buttons. And every single one of the AANP questions will have 1 correct option. Now, let me correct my terminology here. It's not 1 correct option, 1 best option. Best. Okay. How do you tell from the 2 correct? There probably will be 2 technically correct answers, but the story, the stem, the story of the question will lean you towards 1 being the better of the 2 answers. ANCC will have a small percentage of their questions, like perhaps 10%, maybe even less than that, where they will say, choose, they give you the stem, and then they give you the 4 options, maybe 5 options, and they'll say, choose 2 that apply. All right. And you either get both of those correct or you don't get the answer correct. All right. And because that's the purpose of it. But AANP does not have questions like that on their boards. And it's only a small number of the questions on ANCC. Okay. So there's no partial credit for any questions on the boards. And you will never get a question that would say like all of the above, none of the above, something like that. There are no questions like that on boards. I've completed all 3 of the exams offered through the program. My pre-test score was 64. I reviewed the program 3 times. And my second exam score was 80. Excellent. What a great outcome. Congratulations. You then reviewed it again and you went up to 84. Yeah. Oh, that's wonderful. Congratulations. So you know what you did? You increased your knowledge base. You enhanced your clinical decision-making skills. Your test-taking skills didn't get any better. You came to the exam with great test-taking skills, But you did, you just made my day. I honestly can't tell you how happy that makes me. And you know what the other thing? Good for you. You worked it. You just put many, many, many hours into using this course, many hours. And I hope you feel the confidence it gave you. Now, so of course, your final answer is, would you like me to review the course again or take the board certification exam? Once you're getting into, on our exit exam, like a mid-80 score, it is pretty predictive of passing boards. But you and only you know whether you can say to yourself, you know, overall, and you've got objective information here, your score went up 24 points. That's unbelievable. Beautiful, beautiful. But only you know whether you still go like, okay, 84 is pretty darn good. Me patting myself on the back, good for you, because you put in the time. But I'm still a little shaky on whatever. And then what I would say is, okay, if you still feel like you really are a little shaky on like one topic, then review that and then take the boards. Is there anyone who has walked into boards saying, I am 100% confident on every topic I could possibly get? No, there never has been. And if there's somebody that says what I was, ask them whether they passed or not, because I have a lot of people in remediation that will say to me, I walked in 100% confident, and then I look, they failed. Then I look at their score and they scored at about the 8th percentile. So in other words, they did not have the knowledge base that they thought, and you're demonstrating that you do. Are the new hypertension guidelines regarding race going to be updated on the exam? You know what? Here's the deal. They can go in and adjust boards content regardless of the newer guidelines. Because for those of you who aren't familiar, September 2025, so it wasn't that long ago, within the past 5 months, the ACC-AHA removed race from the criteria for diagnosing, not diagnosing, but initial choice of a medication for the treatment of hypertension. So prior to fall 2025, it was black. This is their terminology, not my terminology. Black, start with a calcium channel blocker or a thiazide diuretic. Non-black, in other words, everyone else, you could start with an ACE inhibitor or an ARB or a calcium channel blocker or a thiazide diuretic. And one of the reasons why that race criteria was eliminated, and this was nothing like brand new that all of a sudden somebody decided the day those guidelines came out that they were going to do this. This had been in the works for years, because I remember I taught a class on prescribing and hypertension in spring 2025. And I had a quote from the AHA in there. The new guidelines weren't out yet, that said something to the effect that it is time to go race agnostic with blood pressure guidelines, because too many clinicians were inappropriately interpreting it at that ACE inhibitors and ARBs did not work in people of African ancestry. So I'm going to refer you back to a question that's in the review course. And there's Mr. Jones. He's a middle-aged guy, African ancestry. He's been on a calcium channel blocker for a couple of months. It's right there in your review course. His BP is still too high. I think it's like 150 over 90, still too high. And this is how it could play out. Like, so he's on a calcium channel blocker, he feels fine, okay? The correct answer on that is you add a thiazide diuretic and see him back in a month. That's the correct answer. And when you look at the other choices, One of them, I think, is start him on a beta blocker and see him in 2 months. No, beta blockers are second line hypertension meds. Another one is to tell him since he feels okay, he's okay, and don't worry about it. I don't even remember what the other answer is, but long and short, old guidelines, new guidelines, same answer, same answer. Okay. Because what the boards are not going to do is give you the example of Mr. Jones, who's on a calcium channel blocker, and then say, add an ACE inhibitor or ARB, or add a thiazide diuretic, or add a beta blocker, or add an aldosterone antagonist. No. They're not going to do that, because literally with that guy, with the newer guidelines, you could add either an ACE inhibitor or a thiazide diuretic. Okay. So that would leave you with two correct, equally kind of okay answers. All right. So, and to tell you the truth, with the hypertension guidelines, other than that, there's not that much of a change in them. The new high blood pressure guidelines that include the PREVENT calculator, that's the word PREVENT in all caps, stands for something. Time will show us the real place for those guidelines, but we're not there yet. What is passing percentile for AANP? Both ANPP and ANCC are AANP. Let me try that again. AANP and ANCC. Both of them, you need to score at about the 15th percentile for your cohort in order to pass boards. So that's 350 out of 500, maximum score perfect, 500 for ANCC, 500 minimum versus a max score of 800, which is AANP. So in other words, and if there's anybody on this call who did not pass boards, I do not say this to rub any more salt in your wound, but people who sit for boards are a pretty homogeneous group. You all did a similar course of study, every single one of you. People who failed boards were scored below the 15th percentile for a homogeneous cohort. That's what it means. So in other words, they scored really low. They really did. Okay. I never got a workbook. Okay. Pop a message to Brian in the chat and he can help you out on that. Okay. Getting another never got a workbook. You know what? You folks, there was one school that folks might, there was an extra fee for a workbook. Okay. Anyway, I'm going to have to kick you to customer service on that. Do I have any strategies to understand classes of antibiotics? It's not understanding classes of antibiotics as much as it is understanding which class covers which bugs. So I'm going to do something because we're running out of time here. Very, very quickly. First of all, if you're inpatient working and you see all parenteral antibiotics, there are many of those that you just need to forget about. Just forget about them because they're not going to crop up on boards. But the beta-lactams, and all of this is in your course too. The beta-lactams include any antibiotic with a beta-lactam ring, just a molecular ring. It includes the penicillins like amoxicillin, ampicillin, and penicillin. Amox is the most commonly used. And then it includes the beta-lactams, include the cephalosporins, okay? And they have a beta-lactam ring, but a little protective side molecule on it to keep the beta-lactam ring stable in the presence of beta-lactamase. And you know, if you go over the COPD exacerbation section of the course, I go over the differences between the penicillins and the beta-lactams there, okay? But what's one of the commonalities of the beta-lactams as a class of antibiotics? They do, if you give enough of them, a decent job with covering Streptococcus pneumoniae, the #1 bug causing ABRS, acute otitis media. And if if a COPD exacerbation is caused by bacteria, it can be a contributor there. Okay. Also, that class, the beta-lactams will cover Haemophilus influenzae, Gram-neg, that's also big in AOM, ABRS, and COPD exacerbation. However, those two bugs often produce beta-lactamase, so they can chop up the amoxicillin. And same with Moraxella catarrhalis, that almost all produces beta-lactamase. The tetracyclines, there's really only one of those drugs that's used commonly, and that is the drug doxycycline. And that covers strep pneumo, H flu, MCAT, which is why we use it in ABRS, another number of other conditions that could be strep pneumo, H flu, or MCAT. Stable in the presence of beta-lactamase because it does not have a beta-lactam ring. Okay. The fluoroquinolones, levo and moxifloxacin, cover strep pneumo, H flu, Moraxella catarrhalis, a bunch of other bugs like the atypicals in pneumonia, M pneumoniae, C pneumoniae. Doxy does this too, covers the atypicals. We don't use the fluoroquinolones first line because of the adverse effect profile. Also, I always think of the fluoroquinolones. They're a class of drugs we want to leave on the back burner in case we really need them because their strep pneumo coverage is pretty robust. But what I want you to do as you're going through the Fitzgerald review course, I don't want you to think you have to memorize antibiotic classes. I want you to learn what bugs cause what infections, and you're going to notice the same drugs keep coming up and over again. Before submitting your exam, do you need to unflag the questions you flagged? No, you don't. And the company does not look at, the certifying agency does not look at the flagged questions with disdain. They don't. Okay. And so, okay. The person that said you got it through the school, you're having an issue with customer service, please go to Brian. Okay, put that in the chat. I'm not dodging things. I am not involved in the customer service part. I'm here as your content expert. What about Benadryl, melatonin updates? Will these be on the boards? Okay. Tell me, what do you mean by the Benadryl melatonin updates? Okay. Now, if you're saying Benadryl is not the preferred antihistamine in an allergic reaction or to help with itch, because it's not, oh my God. Okay. Okay. Now I get you. Now I get you. Oh, that's so far off the rails. So far off the rails. It's not going to be on the boards. Okay. But here are a couple of things I'm going to say about Benadryl. Diphenhydramine, that's how it will be on your boards. Diphenhydramine, first generation antihistamine, gets through the blood-brain barrier, causes sedation. There isn't anybody on this call who has not popped a Benadryl after working all night. Let's face it, right? Because it helps you to sleep more. Guilty as charged, okay? A drug like cetirizine, Zyrtec, or loratadine, Claritin, has equal antihistamine effect for an allergic reaction, but does not pass through the blood-brain barrier. The risk, and it's not a definitive risk of dementia with the use of Benadryl. There is a correlation between long-term first-generation antihistamine use and possibly an increase in cognitive issues in older adults. Okay? Okay. Now, the melatonin, I'm not following you on that one. If you're saying that melatonin is correlated with heart failure, that's just, I want to see the study and I want to see the pathophysiology of how it would do it, because correlation does not mean causation. So first of all, that's way too micro. Way too micro. That's not going to be on boards. And it's not an update. It's not an update. So what I want you to do is get back to kind of the basic stuff. And if you're on another one of these sessions and you've got some data for me to look at, I'm more than happy to look at it. But what I want you to do is say, I'm not going to waste my brain space with all this kind of, side chatter that a provider mentioned. I don't prescribe this because of that, but stick to best evidence. Okay. All right. Very good. We are out of time. I want to thank Mr. Austin for being on with us today, and hopefully see you back in a couple of weeks for the next session. Take care and best wishes in your study.
All right, take care, Dr. Fitzgerald. Thank you all for joining.